The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Hey, George. Good to see you again.
Hi, how you doing, Herb? It's Tuesday, midday, elevating great physicians once again. Today I met this Dr. David Epstein. He's from California. He's going to talk to us about an interesting topic, and it's called If Growing a Pediatric Hospital Program Was Only as Easy as This. Basically, he wrote an article and it came up on Kevin MD, and he talked about the way it used to be back in the 90s and early 2000s, and why we can't continue with that road. So we'll take it away. But before we take it away, let's make sure all our audience and our friends, they like or they subscribe or they share this podcast. So let's get this message going out to other people.
Hey, David, welcome to the show.
Yeah, thank you. Thank you. It's nice to be here. Thank you so much for inviting me.
So, David, we always want to know why did you become a pediatrician?
Yeah, that's a good question. I remember going through medical school and start doing my my rotations through the clinical rotations, and I realized that I didn't like anything, and then until I went to pediatrics, that's kind of where the light bulb went off. I remember I thought I wanted to do pediatric surgery, but then I realized that it wasn't the surgery part that excited me. It was more just the pediatric part. And so, I don't know, it was just kind of like a calling. Like, I don't know, you guys may relate. There wasn't anything particular. In fact, my pediatrician probably was surprised that I went into pediatrics because I was the worst pediatric patient ever. But yeah, it was just kind of like a calling. I just kind of went in, and it was like the one thing that just kind of shown out at me. And then as I was going in residency, I was doing that, and I never thought that I would be in pediatric critical care, and kind of dovetailed into that, but I never thought that would be my path. And it wasn't until I just went through the rotation and did the experience that I was fascinated with those kind of things. So that's kind of that was the story. So there wasn't anything special. It was just kind of more like, oh my God, this is what happened.
Right into it. Yeah, that's awesome. From a business perspective, what do you think is similar between a PTD, ICU, hospitalist, and urgent care?
It's interesting because they're being so many years in the intensive care, in the ICU. It's not, I didn't see it as a business model. I didn't see it from a business perspective. I knew that the beds needed to be filled. I knew that we had to be staffed, and I knew there were certain things and supplies and things like that. So I wasn't privy to the business side of intensive care as much as when my wife and I built an urgent care, seeing it from that standpoint and understanding it. But seeing it from that point of view and understanding that some of the emergency room physicians are part of groups, contracted groups with hospitals or intensive care groups, there's always like a budget. There's a budget for anything, and I think you can think of it as widgets. It's obviously you have your physicians, you have your staff that need to get paid, and then you need to have your volume. And when you talk about volumes, you could either have the business model where you get paid a lot for, lower volume, or you get paid less, but you have to do higher volume to make it up. And so when I look at that, I see that the reimbursement, at least in pediatric urgent care, is not fabulous. And, I know primary pediatrics is probably, obviously the same. So you really, it's really a volume practice. And so you really have to see the number of patients, and that pushes through to 10, 15 minutes, per visit, to try to see as many patients as you can to achieve a certain a certain volume so that your reimbursement equals what, obviously your expenses are. Whereas intensive care and emergency medicine, where they're associated with a facility of sorts, I think that there are more opportunities for charging more. There's also more, you have more bargaining power, I think, with insurance companies, with a larger entity that you are, where I know, like in the community, I would always hear from the primary pediatricians, and experiencing it myself, is that like Blue Shield or Blue Cross, or big payers, there was no phone number you could call and talk to a person. You could just fax in your request to update your contract, and obviously you would get a fax back and it's saying no, and it's only if you had leverage that you could renegotiate your contract for something more than you were getting. So I don't know if that answers the question, but I think, the business model from that standpoint, I think that there's, a higher reimbursement, lower volume, probably in the ICU, where it's, lower reimbursement, higher volume in the urgent care setting, and probably emergency medicine's kind of somewhere in between. But if you're associated with a facility, then you probably have more leverage, and you can charge different things, like a facility fee and things like that.
Well, why do you think, or maybe Herb knows his answer, because he was in urgent care business too. Why are organizations such as City MD or PM Pediatrics, why are they successful?
Yeah.
They started off as a one-off solo urgent care.
Yeah. Well, I think part of it too is, depending on maybe if you have investors and you're able to open up more than one. So once you start to get a critical mass, I know that there was an urgent care company in the area who we were familiar with, and we had spoken with them just casually and just kind of getting their insights. And they mentioned that, once they got a critical volume of patients, like, X number, then they can renegotiate contracts. And so I think that if you have investors and you can build out more than one and you start stacking, then your leverage kind of goes up. And I think with City MD or PM, they have that volume, they have that market share, where I think that they can negotiate a little bit better than the individual practice, like mom and pop shop, like we had. So.
But I know for a fact, like the City MD, I think it had 3 or 4 other names beforehand over time.
Oh, really?
Oh, yeah. They were Premier Care, Pro Health. There's like a lot of names. I think the what is it called? The venture capitalists keep pumping money into them and selling out and buying and changing the names and change all the logos and the signs. I mean, it's I don't know. I don't get it. This corporate medicine is not good.
Yeah. It kind of, I think it depersonalizes things. It's very transactional. And I think one of the things which was at the heart of the article that I wrote was, creating a pediatric practice or pediatric program, and creating a community. It's something that's more relational. And I think that was the kind of thing that spurred our discussion a little bit earlier, is that, in the old days, it's, I think things were very, very relational. Of course, there's a business aspect to it, but I think, I think if you want to integrate in the community and be part of the community, you have to have a more relational model, not only amongst the pediatricians in the community, but also the families that you're taking care of as well.
What do you think, Herb? Because you worked in the ER and urgent care and the offices.
I really haven't seen any private equity or venture capitalist group that really has been successful in managing medical practices. They invest in growth, so they'll pump. It's like steroids. They'll pump money into it to grow practices and acquire and aggregate. But they can't. They don't understand the complexity of humanity. And so it's not the same when you're selling iPhones versus you're taking care of people in the ER, you know. If you happen to buy this year, you're going to pay a lot because there's a lot of people with the respiratory viruses, high volumes in the ER. Who knows next year? Maybe the volume will be 50%, and there's advertising doesn't help. So it's a very difficult model, but the venture capitalists, they just want to buy growth, get you to a certain point, flip it into an IPO, and they become very impatient about year 5 to 10 that they're not meeting the metrics that they need, make it an IPO, and then they'd start looking for somebody else to buy it and get rid of it. And then you just become the unwanted stepchild that gets passed around.
Yeah.
I don't know any groups. I mean, I would like to see a group like Warren Buffett, where he buys really solid companies with solid management, with solid business plan, and he's not intent in putting them in steroids and growing them as fast as he can just so he can dump them. He wants to hold on to them for years and years and years and years and develop people and develop the company. I have not seen that in the industry, in medicine and VC capital. I've only seen a lot of disasters where people are, it's an unhappy marriage and they end up in divorce.
Yeah, I have to agree with you on that one. It used to be a time when in order to own a medical practice, you had to be a physician. Do you know that? That doesn't exist anymore. All I have to do is hire you. That can be anybody.
Well, in California, I think when we were setting things up, it had to be a physician had to be a 51% owner. At least in California, that was the way it was. Or somebody in their medical, definition. I don't know if it was only just a physician, but I know that when my wife and I set it up, I had to be 51% owner.
Mm-hmm. Okay.
Yeah, that's still true in Virginia, but it's not enforced. So, I mean, I don't, Walgreens is now owner of City MD, and they're going to employ all these physicians. And I never understood, I can't own a pharmacy as a doctor because it's an antitrust violation. But Walgreens and CVS, they can own doctors and nurse practitioners and put them in their shops to prescribe, but there's no conflict of interest there.
Yeah.
It's good. I think we're evolving. It's a crazy business model right now, and it's evolving.
Well, maybe we should have one of those Walgreens or CVS people on our podcast to explain it to us.
Yeah, that actually Kevin, who's the CMO of Walgreens, is a phenomenally smart guy. He came out of Harvard. I think, if I'm not mistaken, he was also an ER doctor. Out of Harvard, and then did some public health and population health. He was with Athena Health before. Kevin's very smart.
Yeah.
Very nice guy. Anyhow, I wanted to ask you about when you're looking at pediatric build-out models, right? And talking about ICUs, pediatric urgent cares, EDs, sedation services. There are two business models that people follow. One is, I am the Mecca, so I'm going to put my name on top of the urgent care and advertise direct to consumer to the mom, and they're going to come see me. And the other one is, I'm an extension of the community pediatrician, so no one can work 24 hours a day, 7 days a week. So if your kid's sick on Saturday afternoon, or they seem like they might have a Colles fracture, it's not cost. It doesn't work for you to have an X-ray machine in your office, but I can. So send them over to our shop. We'll take care of them for you and send them back and send you a report and call you if there's anything unusual. Which model did you encounter and like best, not only as an intensivist, but also when you went to build out your own urgent care?
Yeah, that's a good question. So when in my upbringing in medicine, being an intensivist, I was in the ivory tower. You're in the ICU, you take care of the patients, they come, they go. There's really not a lot of connection with the community from the ICU. So yes, you're talking like in the cardiac ICU, we would communicate with the community cardiologists, make sure that they were updated on the patients. But for the most part, the communication, you're not in the community or part of the community. the reason being is that, there's not much choice. There are a limited number of pediatric ICUs in the community, and you're going to be sent patients regardless. So it's unless you're a smaller one. I mean, I was at Children's, and so they had a 24-bed peds ICU and a 24-bed cardiac ICU. And I know that there were relational pieces in the cardiac side because they were trying to have relations with the cardiologist to get referrals and things like that. But as far as pediatric ICUs, I think you're getting from the community from mostly. And of course, you want to be kind to the emergency rooms that are sending you patients, and be collegial and things like that. But you're not like stepping into the community part. You're not relying on that as much in that respect. In the urgent care, and it was funny because when I moved into the urgent care arena, you hang your shingle and you're like, okay, we're open, come on, let's go, and you're like, you can yell and scream all you want, but nobody's showing up because nobody knows you're there. They don't know your reputation. They don't know who you are. And when we initially started, we were just doing grassroots, foot on pavement, walking into the pediatrician's office, introducing ourselves, saying what we're doing, where we're at, and we got feedback like, well, why are you here? Why are you open during the day? We're here, and it was, I think for that part, that aspect, some people were afraid that, we were going to be taking their business, or, replacing them. And that wasn't what we were out for at all. But in the beginning, it was like, you really isolated, and, just because you hung your shingle didn't mean people were going to show up. And so from the urgent care model, learning that it was really a relational piece and connecting with the community and being part of the community, pediatricians, being an extension, like you mentioned, I think that was the important piece there. I don't see that is an unimportant piece in the ICU anymore. And I actually think that can actually augment, the practice in the ICU. But I just think that it's overlooked because maybe things are busy in the ICU and you're focusing on other things. But I think as far as growing any practice, whether it's in the hospital or whether it's in the community, I think connecting with people is the way to go. And it's actually more fun. I think that's what I enjoyed about when we were doing the urgent care, and I'd have a patient come in and they, it was, a patient with a history of something or other. So they come in and they have issues, and I said, hey, who's your pediatrician? They say, Dr. So-and-so. And I say, oh, okay, let me give them a call. And I just quick, speed dial them on my cell phone, give them a call, say, hey, we got, your patient's here, this is what's going on. I know that you've seen them before. This is kind of what we were thinking of doing. You have any recommendations, or just including them in the care and being collaborative. It was so satisfying. It was so, it really kind of brought things together, and like, hey, you're part of the community. We're in this together,
Right.
And that was, I think that was the joy that it brought me. And, it really created some bonds with the community where, I'm still, friends or, colleagues, with the, pediatricians in the community now. We interact and things like that. And so I know it's a long answer to your question, but
And I bet you the parent appreciated that.
yeah. Oh yeah.
I remember back in the day, you used to go make rounds in the hospital. You'd see the ICU attending. You'd see whatever, the specialist. You'd catch them at the grand rounds. Now, I mean, my office still goes and makes rounds at the hospital because I think it's the right thing to do. If they get admitted to the ICU, we'll bump into them by accident and they'll tell us. But if you don't go to the hospital, you're not bumping into anybody, you're not speaking to anybody. Maybe you'll get a piece of paper, maybe. And that's the whole relationship. So I think the moment that the doctor stepped foot outside the hospital and gave up all privileges, that was, the profession is getting, it's doomed.
So
Yeah.
I'll push back a little bit on that because the person I learned a lot of the business side on critical care and ED and hospitals work was Chuck Chavino from Michigan State University in '89. And Chuck was the director of pediatric services for an 800 bed regional hospital. And I don't know how Chuck did it, but I mean, he really was OCD, but um, he knew in Southwest Michigan is such that there's a town where Bronson sits, and then everything around is rural, so very small community hospitals around it. But keep in mind, in '89, community hospitals were taking care of meningitis because there was just so much of it. You couldn't put every kid with meningitis in the PICU. It's just not possible.
Yeah.
But he was very strict. We want to pick up a kid at at a small community hospital, really in the podonks, and you have to get that pediatrician or family practitioner's name, not the ER, the primary care doctor, the community doctor, and bring it back to you to the ICU. And as soon as the patient was stable, he would pick up the phone and say, "Hey, George, I got your kid here. This is what's going on. He's stable. I think he's going to make it. If you need anything, here's the direct number to the PICU." We didn't have cell phones then. And Dr. Bravo is the intern on call tonight. Call him anytime you want. Ask him anything you need. And, and then when, because of the distances, they couldn't come to the hospital to see their kids. And so they would go from the PICU into the ward and the pediatric referral service, the hospital service, which was the intensivist, would take care of them through the entail of the hospital stay. And then before they went home, they would pick up the phone. Chuck would pick up the phone and call George again and say, "Johnny's ready to go home. He's going to need these medicines. He's going to need the following follow-up. Thank you for sending me Johnny. And you know what? I'll send you a letter. Dr. Bravo is going to dictate the letter, but I'll make sure you get a letter for your file." And you couldn't discharge that patient until that letter was dictated. You dictated and his secretary would type it up.
Yeah.
And, God forbid you forget to call the community attending before you sent that kid back into the community, because Chuck will have your head, on a pole. And there was zero tolerance for not communicating with the community every day.
That does lead to good quality medicine.
Yeah.
I speak to you. There's things that need to be followed up, things that need to be done, medicines that need to be represcribed. Now we get hospital follow-up. Unless we saw them in the office and we have a progress note that we brought back, I got to ask, why were you in the hospital for? How long did you stay? What was your diagnosis? And most of the time, they don't know what they had or what to do.
And I asked the question of Chuck. I said, these people are really busy. I mean, back then they would see 50 kids in a day. It was a zoo. And why am I interrupting their workday for, the kid had pneumonia. He's better. He doesn't, he's like, because you close the loop. It's good care.
Yep.
It's their kid. It's their patient. It's not ours. It's theirs. We just got lucky enough to care for them in the hospital. And you need to make sure that they know what's going on so that when they walk back in the office, they go, "Yeah, Chuck called me. I heard you had a rough time. I'm glad you are doing a little better. This is what we're going to do."
Yeah. Well, maybe too, like now things have shifted. So when they're in the ICU and they get out of the ICU and they go to the floor or they go to the step down, maybe that's where the communication happens with the primary. But like in the ICU, my experience has been, it hasn't been where, we're connecting directly with the primary, pediatrician all the time. And I don't know if it's regional. I don't know. I mean, but your experience, that's beautiful. I think that's the way it should be. And now it's interesting that, being in intensive care informed me on how to do urgent care, and urgent care informed me on how to do intensive care. So it kind of each affected how I provided care. And it was interesting because I was recently on call at one of the hospitals, and we had a sick patient come in, And I asked the family, I said, hey, who's your pediatrician? Do you have their number? And so I got it. And then, I called them and I said, hey, this is what's going on. This is, and they were so appreciative. But had I not done urgent care and exposed myself to that kind of care model, I don't think that I would have been as prone to calling the primary pediatrician and just kind of updating them, because that's now just kind of what I do, which is, so I don't know, it's kind of my evolution, I guess. Maybe that's what it is.
Yeah.
I wonder if this is a generational thing of not talking to people, because when we see a patient, and we send a lot of patients to the hospital for admission and whatnot, there are a lot of patients. I tell all the doctors that we should call the ER as a courtesy to give them a heads up that I have this patient, to give them an initial intake at what I think is happening.
Yeah.
I ask to speak with the physician. The old school guys are all there. They pick up the phone. Yes, we'll do this. We'll make a little plan. Thank you very much. But the new hires, they say, just tell the secretary that what's the name and the birthday.
Mm-hmm. Yeah.
They don't even want to know. It's like, really?
Yeah. And maybe it's a pendulum swing. Maybe it's going to, start to shift back as people realize that, I think my wife's a therapist, and, I hear a lot of these, and actually she cared for, physicians actually, at a hospital. And so she, was the physician support at a hospital. And, physicians are people too. And I think some of the things that are missing is probably some of the humanistic parts that are being washed out and causing, the burnout and causing the moral distress and all these other things. And at the end of the day, I think what it boils down is to human connection.
Right.
And and possibly maybe the pendulum's going to swing the other way and be more relational instead of transactional. But I guess a lot of that depends on how busy people are, because it takes time to pick up the phone, and it takes that extra effort.
Yeah. I mean, I even see people that are in the hospital medicine. They do their sign outs through text message.
Wow,
that's crazy. You're gonna miss it. But they do that. Or the computer through emails. They don't even talk.
Yeah.
So I guess that you found out the importance of the relationship with other pediatricians when you're building up the urgent care. Not only how good that's for business, but for quality and for satisfaction of your own personal satisfaction as a physician.
Yeah.
That was a lesson you learned in the urgent care.
Yeah.
It's definitely, it's very good for business if you're close to the general pediatricians and you're in the urgent care.
Yeah. And it's part of building a community and being part of something. I think what I realized that, in the hospital, you're part of a big organization. There's a lot of chance for engagement with colleagues and people, grand rounds and M&M conferences and, teaching conferences. And so you're always engaging with people. But when you're out on your own, it's just you, and there's not that kind of collegial engagement on that kind of level. And so one of the things I think is that, as being in that environment myself, it's like I craved kind of talking to other doctors or talking with my peers and being part of something, bigger, and being part of the community. And I think that's, something that I sought out, coming away from, the hospital environment and going into the community. And so I think that was, some of the inspiration to try to kind of engage with others. It wasn't, it may have started off as, okay, we need to, do grassroots and expose ourselves to the pediatrician so that we get business and things like that. But at the end of the day, I think it was all about connection and just feeling to being part of a community.
Oh, absolutely. Absolutely. For me, the ER, the most fun part was the relationship you had with every physician in this on staff. I mean, when you're in the ER, you know everybody and you know them in good days and bad days, you know, because undeniably, you wake up somebody at 3 a.m. and say, I need you to come in and help me with this kid. There are very few people that are going to come in dressed to the nines with a big smile and a bottle of wine for you. You know, they're like, oh God, you know, and then they're not mad at you. They're just mad at the circumstance that they're having to come in after they put in a long day of work, and, you know, they finally were down to bed with their families. And, but even though, you know, it's always very nice. It's just, you know, they tell you, you know, this happened today, so I've had a long day, and it really sucks to have to be here, but let's go take care of this kid.
Yeah.
And that was very, very much fun. That was a lot of fun.
Yeah.
And when I left the ER, one of the orthopedic surgeons, I bumped into him on the hallway, and he said, you know what, Herb, is just not the same. I'm like, what do you mean it's not the same? I left you 5 pediatricians. He said, there's just something about looking at your white old Mercedes parked in the doctor's spot in the ER when I came in to take care of a kid. That was so reassuring to me, and it's gone.
Oh.
I'm like, well, thank you. He said, no, I mean it. He said, I knew that I could do my job and the rest was going to be taken care of, and that meant a lot to me.
Yeah.
And that I mean, that really is worth a lot. It's just, you know, that prevents burnout.
Yeah.
You know,
Yeah.
that it's very nice to have that. Anyhow,
That's a
I'm a
nice
little
story.
I'm a little biased because I think anybody who tries to start a stand up a standalone urgent care is a little crazy, including myself.
Yeah.
It's a lot of work.
Yeah.
Yeah.
But why did you? What was the genesis to go from, you know, the protected Mecca to the real world and put your money down where
Yeah.
your mouth is, and, you know, run this whole organization from, you know, from 0 to 100?
Yeah, that's a good question. I'm still asking myself that. No, I'm just joking. No, my wife and I. So in our community, there was a pediatric urgent care, and it was actually run by a pediatric intensivist who'd come on before I knew her in the community, and for personal reasons, she had to close the urgent care, and we'd actually been there ourselves with our kids, and when that closed, there was really nothing in our area. You know, you think of LA as being such a big city, but there was really no defined pediatric urgent care in our area, which was one of the impetus for saying, hey, let's, you know, there's a void. We needed it. I'm sure other families needed it too. And so that's what, that was our inspiration. Did we know what we were in for? Absolutely not. Absolutely not. We were like, let's just open an office and we'll help the community. We'll have these resources. We'll do this. And it really turned into a much bigger project than we could ever have dreamed or thought of. And so it was kind of a little bit of, you know, just a little bit of naivety on our from our standpoint, because we didn't have anything to reflect on or to know, just because there weren't any in the area. So, and yeah, it was just that's kind of what happened, and it kind of grew, and it came to the point where actually we opened in 2015, and I was still doing critical care up until 2019, where it just kind of became impossible at that point because I couldn't, you know, it wasn't a hobby at that stage. You can't do it as a hobby, so I had to kind of leave and dedicate my full time to the urgent care at that point. But yeah, it was that was the impetus for starting it. And, you know, we think about it, what we were able to do, and you try to look, you know, hindsight being 2020, would you do it again? Yeah, we made a lot of sacrifices. I think there were a lot of demands, you know, on the family time, things that, you know, because you're open 7 days a week, you know, 12 hours a day at that time. And you know, there was a significant demand. I mean, somebody calls out sick, you know, it didn't matter if it was a front desk, x-ray tech, nurse, physician, you know, if somebody called out, you know, we stepped in. So it was like, you know, it had to keep running. We, you know, and I think during that whole time, I think we only shut down for one day because of staffing, and it was opportune because, you know, we had to repaint the place anyway. So it kind of made it work in our favor. But you know, it was a lot of work, and we did make the sacrifices, you know, as the time and energy and things like that. But we really feel like we made a good impact in the community, and to the point where people really appreciated us being there, which kind of gave us a fuel to keep kind of going at that standpoint.
And what happened to urgent care? You closed it down?
Well, it was acquired. We were acquired by PM Pediatrics. So that was in April of 2021. And so since then, I worked there. I stayed on as medical director for about 6 months, and I kind of stepped down to do kind of more just per diem, just so I can kind of get back into intensive care, because that's kind of what I missed. You know, that's my home. So
yeah, PM Pediatrics, they seem to know what they're doing because they're pediatric focused. I don't think they're wholly, you know, venture capital driven. I still look at them as a private entity, a private practice, because if you think about all these meccas and these networks and systems, they have their hospitals, they have their practices, and they make a small footprint of an urgent care that feeds the mecca.
Yeah.
You know, and so basically they're getting pushed away also. You know, they're looking at a collaborative model. I mean, we're working with them with our clinically integrated network, where we have independent practices with different tax ID numbers working together collaboratively to do good quality and to reduce emergency room visits, sending them to PM Pediatrics. And now they're developing their behavioral health model also. We're going to try to work with that. So I think that's the way it is. But you hear, it's relationships.
Yeah.
Relationships, do good medicine, the money will follow.
Yeah.
Yeah, I think the urgent care space, longevity is short. The at least on the commercial side, the payers are not happy with the urgent cares. They see them as an unnecessary expense. And
if people are going to go to the emergency room, their doctors are not going to see them. Don't you remember during COVID, the lines around the block at the urgent cares at the city MDs? It was crazy.
Yeah. And in our community, the pediatricians, I mean, they weren't seeing sick visits. And so we were seeing, you know, all those patients. Also, you know, there are a number of things where you think about going to the emergency room, you know, a child, I mean, sure, you guys saw it all the time. It's like they have a runny nose, cough, congestion. They really shouldn't be in the emergency room. You know, that's a huge expense for the insurance company. Also, you know, to see like a fractured finger, you know, it's like, you know, you just do an x-ray, you put a little, you know, splint on, have them follow up with ortho or their pediatrician, whatever, you know, the preference is, and you're done, rather than, you know, right now, I think at some of the major hospitals, I'm sure you guys have those kind of numbers too. I mean, the wait time to be seen is like hours and hours and hours. I mean, it's like, you know, it's bananas. So, I mean, we'll see how it goes. I mean, you know, urgent cares are opening. I know that there's a particular company out here where they're just keep on opening urgent cares. You know, they're popping up everywhere. So,
you know, a lot of the urgent cares that I've seen in the past, I always wondered about them because you walk into them, it was a huge footprint with marble bathroom tiles.
Yeah.
And it was really granite countertops. I always wonder, how do they make money to pay for all that stuff? So
Yeah.
I always have to agree with like the meccas where they have, you know, small footprint, 2 or 3 rooms, one doctor doing some stuff and then sending them off to the mecca if they need anything. You know, that might be cost effective. I don't know.
Yeah. Well, I know like when we were doing some of our research, I mean, like I know in Seattle, there was one major hospital that actually rented a particular space to an urgent care for like peanuts, just so they could have the urgent care there, so it could offload, the ER, because the ER was getting, these unnecessary visits and things like that they would lose money on. So it actually was, financially better for them to have them seen at an urgent care instead of filling an ER bed. So, I think that there's a place for them, and I think as time goes, it will evolve. But when you look at some of the big urgent cares, where they see everybody, kids included, I'm kind of, I think that's kind of a little bit hard as a pediatrician, because we would always hear about some of these, take all urgent cares, and they're prescribing, crazy regimens for ear infections, or saying that there's an ear infection, there's really nothing there. I mean, we hear from pediatricians in the community all the time that it's not as good medicine, and thankfully, for having pediatric focused urgent cares, at least you have people who know what they're doing as far as kids go. But you're talking about like these marbled, meccas. I mean, the adults coming in, I think the adult reimbursement is much better than pediatric reimbursement. So I think that they have a step up on that. And so maybe it's easier for them to kind of survive than pediatrics.
Yeah. Yeah. I went to a couple of meetings where, you had a lot of, this happens in the city, where you have a lot of the practices that are capitated, right? So they're supposed to see their patients for checkups. If they're sick, deal with them, and so forth. And then you have the urgent cares close to these offices, open up during the day. And I asked them, I said, how do you guys stay in business? Because the doctors are open during the day. He says, yeah, but they won't see their patients. They'll all come to the urgent care for their ear infections, their runny noses. So these guys are capitated. Urgent care are, all inclusive. It's great. It's a great business model. And that's why the venture capitalists get involved in this.
Yeah. And some of the pediatricians' offices are very busy as it is. And we would see, overflow for sure, because they're like, we can't see our pediatrician for 3 weeks, and to no fault of the pediatrician, because I mean, they have to see well child checks, and they have, their schedules that they have to go by. And so I think if an acute problem comes up, that's why we're there. And especially things like lacerations, where that takes a particular amount of time, in a primary pediatrician's office, unless they're equipped. I mean, that would be, a higher demand for them, while they're seeing their flow of patients. And that's what urgent cares are equipped to do. I mean, so I don't know.
Yeah, there's no way you can do laceration repairs in a general pediatric practice.
Yeah, they usually nobody has lacerations anymore. Everybody's with their video games. Nobody's riding a bicycle or climbing a tree.
Yeah, it's just it's labor intensive. It's time intensive, and you just get so backed up that it's really hard to do.
Yeah.
Unless you got a dedicated sick visit person that's basically a walk-in clinic within your big umbrella, and then they can do all of these things.
Yeah.
But it's just the flow is very difficult. And the volume of those heavy in the urgent care is a lot less than what you do in the peds office.
Yeah, it's just mild to moderate illness, basically.
Yeah.
Some injuries, some testing. Not rocket science.
Yeah, nothing's rocket science.
Except for rocket science.
Yeah. So having gone through this journey with the peds urgent care and with your wife's help, it seems like everything that goes around comes around. And the psychologists will tell you this very often, is like, we're still herd animals. We need to be in touch and close to other humans to maintain our sanity. So you discover the importance of the relationships for your own well-being through the urgent care.
Yeah. Yeah, absolutely. And you know, and it's funny because when the pandemic hit and, you know, everybody's feeling kind of further isolated because it's like, okay, you know, everything's closed down and, you know, you feel like you're a little man on an island kind of thing. As I think that was the impetus for us, you know, the pediatricians in the community getting together. And I think it really saved us from, you know, like a sanity standpoint because we had each other. And we didn't have like a big hospital to lean on. And I remember, you know, there were at one point, you know, we had a Zoom where because pediatricians were going to be asked to help staff the hospitals in the surge. And they were freaking out and they're like, you know, I don't even know how to put an IV in, or I don't know, you know, that. I said, okay, well, let's go through this, you know. And so we went on Zoom and I showed them how to put an IV in, you know, and there were other things where one of the pediatricians had connections with getting masks. I mean, in the beginning, like I remember I had some N95s and gowns that were, and some goggles that were part of like a hazmat, just in case we had some kind of toxic spill or whatnot, never thinking that I would never in my wildest dreams need to use them at any time. But when I needed them, they were gone in like a week, you know, that was done. We're done. And so we're looking around, like when the pandemic started, we're like, where do we get masks? You know, all of a sudden we're not able to get masks and we're not able to get, you know, N95s because everybody was, you know, it was going crazy. I mean, you guys know. And it was the pediatricians in the community who banded together. And one of the guys like, hey, you know, I know a connection. I'm going to get some masks. I'll be dropping them off, you know, here. I'll come to each of the offices and give you guys some, you know. Another guy said, hey, I had some people donate some N95s to me, you know, at the urgent care. You know, you guys are seeing all the sick kids. I'm going to come give them to you.
That's
you
so
know,
nice.
it was like beautiful, you know, and we kind of kept that bond. And even today, like I'm on a texting chain, you know, 18 other pediatricians where, you know, they just kind of, somebody texts something about, you know, oh, this happened with a patient, or this, you know, and you have the whole group kind of chiming in. And, you know, I think that's what kind of got us through the pandemic is that community and that socializations and being together. Because, you know, if we didn't have each other, we wouldn't have been able to get through for sure.
Yeah. Back to the community.
Yeah.
You know, did the hospital help in this? Nothing.
You know, I think as time went on, as they kind of got themselves together and, you know, but it takes time, you know, like with, you know, it was funny having your own business, you realize that you're very agile, you know, you decide like, okay, I'm going to do this. And then you did, like when we were doing COVID testing, we said, okay, let's just do COVID testing. You know, we'll have the supplies, we'll test them outside, we'll have people drive through, boom, bada bing, bada boom, you know, you're done, send them out, da 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 da. It was easy. We didn't have to think about anything. We just did it. I think when hospitals are bigger systems, it takes time to move, and they're not as agile when it comes to that. And so it took time. But one of the things that was nice was the California Medical Association had this thing where they're providing PPE, you know, for a discount. Like, you know, they would actually in the beginning it was free, and after that it was discount. They'd send you this big box that had N95s and gowns and, you know, gloves. I think it was just, you know, they just sent you PPE or and shields and things like that, and it was great. But it took time for the hospitals to kind of organize themselves. It wasn't as easy. So obviously in the community, you know, it was like we were by ourselves, you know, in the beginning.
Yep.
So.
What 3 years now, right? We're 3 years into this. It's been a long time.
Yeah. But, you know, I think there's a, you know, like a silver lining, I think, as we made, you know, obviously it was horrific and, you know, would never wish this to happen again, or I wish it never happened. But if you're looking at maybe some good things that came out of it, is that we built some bonds in the community and friendships, and we worked together, and we got through this, and we got through intact, that in itself is a gift, I think.
Absolutely.
Yeah. All right.
Absolutely.
Cool.
Well, was there anything I didn't ask you that you think you want to share?
No, I think, you guys do a great job. I mean, I really kind of think this idea of a podcast is great, just to chat and kind of, bring this to the pediatric community. And it's a great idea. So
help share the podcast with your friends and all your doctor friends, and, like it, subscribe it, click it, whatever it, just get the notes.
Yeah. Well, I got you on my my post list. So
That's great.
Okay.
Well, thank you so much for taking time off your busy schedule to join us today.
It's my pleasure. It's my pleasure. It was great speaking with you guys, and if you need anything in the future, let me know. But this was a pleasurable experience. Thank you so much.
Likewise. Hopefully we will meet in person someday somewhere.
Yeah, exactly. If I'm ever in DC or New York, I'll give you guys a call.
Yeah, definitely.
Definitely.
All right.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.